evening, dear colleagues, students, residents. I'd like to thank Dr. Salman Sharif for inviting me to this meeting. Actually, I prepared 3 cases and some videos, but here we have not enough time. And then I will present you on one case. I have questions here, but probably I cannot ask the people. Maybe, okay. Okay, this case is 22 years old, young man. He was applied to hospital after motor vehicle injury 80 days ago to other hospitals with only neck pain, head deviated to the front and the right. There was no neurologic deficit, and CT in the first application was as shown here. Actually, when you look here, it seems there is no malalignment here. But when you look to this axial view of the CT, maybe this will be my only one question. Do you see anything here?
Yes, unilateral facet fracture with rotation.
And, yes, there is no actually big or overt malalignment, but here we have pedicle and lateral mass separation fracture. Actually, they sent patient to the home because there was normal alignment, and my other questions are: can you define the injury? Actually, this is lateral mass pedicle fracture separation. Do we need MRI? Actually, in most of cases with cervical spine injury, currently we use MRI to see if there is traumatic cervical spine, cervical disc herniation, or soft tissue injury, or discoligamentous injury. And MRI also will show us spinal cord better than CT. You can see epidural hematoma, subdural hematoma, intramedullary hematoma. Therefore, MRI is enough. But in the first application, there was no MRI in this case. And the question is, in such a case, what is the treatment of choice? Conservative or surgery? Actually, for type of the surgery, we use many different scales. Recently, we use SLIC, cervical spine injury classification system, and based on SLIC, we decide to the treatment type. And of course, the other question is the timing of the surgery, if there is indication for surgery. I would like to show you the SLIC. Here we can see this scale has 3 different components for morphology of injury. If there is no problem, 0. This is 0. For compression, this is 1. For burst fracture, 2. For distraction, 3. For rotation and translation, 4. And based on this presence or absence of the discoligamentous injury, they receive 0, 1, or 2. And for neurological condition, they receive 0. And for complete spinal cord injury, 2. For incomplete, this is very important, they receive 3 points. And based on the SLIC classification, if a case has more than 4 points, there is indication for surgery. Less than 4 points, there is no indication for surgery, and for 4 points is gray zone. So when we look to CT of this case, lateral mass fracture separation is one component of the translation rotation, which receives commonly 4 points. Where you can hear here in translation rotation type of the injury, we have different components: unilateral facet fracture, bilateral facet fracture. You can see here facet here, dislocation, and facet on the other side. And for fracture, this lateral mass fracture separation also 4 points. This case came to a hospital 80 days after the first surgery with such a dislocation. And MRI showed dislocation better. You can see here, fracture line here better. And here you can see fracture lines. See, there is a free-floating facet complex here. So the question is what to do. In this case, we made a fusion from anterior, reduction, and fusion from anterior and posterior. You can see here post-operative image. So my message is use regional detailed CT for injuries. Whole spine CT may miss or underestimate some findings. Lateral mass pedicle fracture separations receive 4 points in SLIC, and they should be accepted as unstable cases. Thank you. Okay.
Okay. Well, I've got 2 case scenarios for you. They're fairly simple. Case 1 is an 18-year-old male, while doing one wheeling, lost balance and hit back of his head on the ground. So brought to ER by his friends within half an hour of incident. And he was a little slow to respond initially and unable to recall the events, but well oriented to person, place, time, moving all 4 limbs. The reassessment was done after 15 minutes. He was found to be a little irritable and complained that he had a pain in the back of the head. The head hurts. How will you respond? What type of physical examination would you like to do? Are you worried about anything about this patient? You would look for the point tenderness because it's the head, so it could be a spinal injury. Range of neck movements, level of consciousness on the basis of Glasgow scale, or just find any other associated injuries. Now, there was no point tenderness. The movements were good. He was found alert and orientated. Now, my question is, would you order a cervical spine X-ray? So, what are the guidelines of doing X-rays in these patients? There are different guidelines. National Emergency X-ray Utilization Study, and that basically shows that there is no point in doing an X-ray if you don't have spinal tenderness, or the patient is not intoxicated, or if there's a patient is fully alert, or there's no neurological deficit, or there's no pain. So this patient, and there are also other criteria. There's Canadian C-spine rule, that's little detailed, and they say that if the patient is able to rotate neck actively 45 degrees right and left, there's no need for radiography in these patients. So CCR is superior to the Nexus criteria and more specific and more sensitive. So there was no point in doing cervical spine X-ray because there is no tenderness and the patient did not have any neurological deficit or any numbness or anything like that.
Actually, the recommendation is that you need a radiology, you need a CT, skeletal reconstruction. So I find actually only recommended if you don't have a CT.
Okay, but when would you go for CT? Would you go for CT in this patient?
Exactly the same criteria applies, but you
Yeah.
don't do X-ray anymore. X-ray is not recommended.
Okay,
It's only recommended if you don't have CT.
and if you're going for a CT, you should go for a sagittal reconstruction and axial cuts. It takes a lot more time. But just you should be aware that when would you go for any investigation in a patient who who does not have any neck tenderness and who does not have any neurology in the arms. Now, does this patient require a CT brain? Would you go for yes or no? Why? Why would you go for CT scan in this patient? Patient is conscious. Excellent. This patient has a retrograde amnesia. So there are different things, but just to cut the story short, you would go for CT scan in a patient who has retrograde amnesia. Also, this patient was doing one wheeling. And one wheeling, if you have a fall from more than 4 meters, even if the patient does not have retrograde amnesia, you should go for CT scan. So this patient was doing one wheeling and it was definitely more than 4 meters. So this patient had a CT scan and the CT scan showed this. So what's the diagnosis? Concussion injury, of course. So this patient had brain concussion. What's the post-concussion syndrome? Anybody knows? This patient had headache, patient irritable, lack of sleep, fatigability, maybe vertigo, all these. Do they recover on their own or? And what's the time bar for those post-concussion syndromes to get better? Do they get better? Mostly. What percentage and what's the time limit? Is it 6 weeks? Is it 6 months? Is it 1 year? Yeah. Just most of them is 95% they will get better. And what's the role of the physician in treating post-concussion syndrome? Just reassurance and symptomatic. Now, what will you do next? This patient, repeat CT scan in 6 hours. You had it one and there was a concussion, there was no hematoma or any contusion. Discharge to home with written head injury instructions or admit this patient to trauma service for at least 24 hours. I think B is a good option. Send the patient with the head injury reconstruction. Now, how long will it take him to get back to his cricket team in college? Asks his mother. When he feels like, when his mother thinks he's well enough to play, or after further evaluation demonstrates that he is no longer suffering from post-concussive syndrome. C, I think. C is the answer. So the nutshell is, in a mild head injury, if you have a retrograde amnesia, or you have a fall for more than 4 meters, you should go for CT scan. And you can discharge the patient with head injury instructions. And also, if you don't have any neck tenderness or any numbness in the arms, legs, any focal neurology, and your range of neck movements are full without any pain, there is no need for any X-ray or CT scan of the spine. Now, just again, a very interesting scenario. A 12-year-old got head-on collision with a car while riding on his bike at high speed. He is brought to ER an hour after injury by rescue 1122. On arrival, he was conscious and able to verbalize with some difficulty due to severe pain in the chest. What are the 5 key components of the primary survey? An accident, pain. So how would you assess? Airway breathing, airway maintenance, cervical spine protection, breathing, ventilation, circulation, disability, and E is exposure. So you have to expose this patient completely to exclude other injuries. Now, is there any problem with the airway in this patient? You talked to the patient, he responded, spoke his name. What's your assessment of securing airway? Would you put an airway in this patient? No. If somebody talks, is conscious, there's no need to put an airway. Now, how about the breathing? This patient, you observed that the breathing was 35 per minute with asymmetric chest movements. And on palpation, there was a crepitus over the left chest, the trachea is in the midline, but the left chest was silent on auscultation. What comes to your mind? Silent left chest, but no midline shift. And the patient is tachypneic. It's going to be pneumothorax. And you don't have to have a midline shift. That's the classic teaching, but you don't get midline shift. This is the real case I'm telling you. Now, this is the X-ray. Anything abnormal you see in this X-ray? Anything abnormal? You mean this one? This little layer here. There are no bronchovascular marking here. So there is a collapse, there are lack of bronchovascular markings here, and there is a subcutaneous air here. What will you do for this? This is a case of pneumothorax with a collapsed lungs, with subcutaneous emphysema, and there are fractured ribs. Actually, the resolution is very good, but the arrows showed multiple rib fractures. Rib fractures, pneumothorax, lung collapse, subcutaneous emphysema. What will you do? Put a chest tube in. We put a chest tube in this patient. See, the bronchovascular markings have gone to the periphery. So what else will you do? Yeah? We like to do something else. This patient has got a pneumothorax. Start 100% oxygen with a non-rebreather face mask. Why do you want to use non-rebreather? Because you don't want your CO2 to be raised. Yeah? And keep him pain-free. You can give intercostal block for the refractures. Now, circulation, there's no active bleed, but his blood pressure is 100/60, and there is no bruise on the abdomen or any swelling. How will you resuscitate? And what's the cause of blood pressure 100/60? Yeah? Yeah, but he could have some other injuries, spinal injury. Pardon? No, I never said that. I never said that. Absolutely, yes. And we will know when we come to the disability assessment. So disability is a neurological status. We did a quick neuro check and found zero power in both legs, sensory level at L1, and loss of sphincter control. Could that be the cause of low blood pressure? Spinal shock. And how would you resuscitate this patient? What would you give? Yeah? Would you give blood? Would you give crystallite? Would you give colloids? What will you give? Crystallites. Acetonic saline. Ringer. Now, what imaging will you order? did an X-ray, and what do you find on X-ray? Is there anything you can find? Okay. And this is exposure. What's this? This is the burn, the contact of the leg with the silencer. Now in the secondary survey, how will you proceed with the chest injury with the secondary survey? This patient had a chest tube in, and the X-ray showed lung collapse, pneumothorax, subcutaneous emphysema, refraction. Would you like to proceed with some secondary survey for the chest injury? You would ask for CT chest to exclude parenchymal damage. Would you go for it or not? You will. And this is the CT chest done in this patient. Can you see anything in it? What's this? It's the same patient. It's the chest tube. Good. Can you see anything else? This is the lung parenchyma. This is the left side. You see something black here. This is actually the lung laceration. So this patient had CT proven lung laceration causing pneumothorax, subcutaneous emphysema. Now, will you advise mechanical ventilation for him? What are the points in favor of mechanical ventilation? There are multiple refractures, pain affects breathing effort, it may aggravate hypoxemia, there's a lung contagion, problem with the exchange. And the points against are that in presence of pneumothorax, the positive pressure ventilation can lead to tension. But he was managed actually without ventilation. So we just do the aggressive pain control, and physiotherapy would be good enough in this case. Name the 2 chest complications this patient is at risk for. What complication this patient can have? Any trainee here? Well, just simple. Atelectasis and pneumonia. And how would you prevent that? You're going to give anyway, but you know what's causing it? This is a collapse. You will do this thing, experiment. What further imaging will you go for his spinal injury? He already had a chest, he had a spinal X-ray. Okay. So we went for CT scan. What does it show? What type of fracture is it? And how many columns are involved? It's the first fracture. Now, if this patient had a complete paraplegia, how many score would you give on ASIA motor scoring system? How many numbers would you give to this patient out of 100? This patient has a complete motor paraplegia, 0 power in both legs. 50, last 50. One leg and one arm has got a 25. So arms are okay. So legs, so it's a 50 out of 100. Okay. So it's Asia class A. Will you fix this and how and why? Just did it posteriorly, understand? Thank you.